Hello everyone, and welcome back to This Week in Pulmonary and Critical Care Medicine, your clinical intelligence briefing for staying current with the latest evidence in pulmonary, critical care, and interventional pulmonology. Every week, we go beyond the headlines to focus on what new research actually means at the bedside. The goal isn't simply to review studies, it's to identify the findings that have the potential to influence how we think, how we make decisions, and ultimately, how we care for our patients. This week, we'll explore how automation may improve oxygen therapy, why advanced bronchoscopy is becoming a compelling first-line option for peripheral lung nodules, and why understanding heart-lung interactions can change the way you manage ARDS. Let's get into the evidence. Every clinician who manages hospitalized patients receiving supplemental oxygen has experienced the same challenge. You prescribe an oxygen flow rate, the patient looks stable, and you move on to the next bed. But what happens over the next several hours? The reality is that oxygen requirements change constantly, while oxygen flow is often adjusted only intermittently by busy clinical staff. That means patients can spend considerable time outside their intended oxygen saturation range without anyone realizing it. The question is straightforward. Can we do better by allowing technology to make these adjustments continuously? That was the focus of the SAVE-O2 AI trial published in JAMA Internal Medicine in August 2026. This multi-center, randomized clinical trial evaluated whether an autonomous oxygen titration system could keep hospitalized adults within their prescribed oxygen saturation target more effectively than conventional clinician-directed oxygen adjustments. The investigators enrolled 300 adults across 4 U.S. hospitals. Patients were hospitalized with acute respiratory illness, trauma, burns, or following acute surgery, and all required between 1 and 10 liters per minute of supplemental oxygen. Participants were randomized to receive either standard manual oxygen titration or an autonomous closed-loop system that continuously adjusted oxygen flow over the first 72 hours after randomization to maintain an SpO2 target of 90% to 96%. Now, it's important to recognize what this study was and wasn't designed to answer. The primary outcome was not mortality, ICU admission, or hospital length of stay. Instead, the investigators asked a more fundamental physiological question. How much time do patients actually spend within their prescribed oxygen target? And this is where the findings became difficult to ignore. Patients managed with autonomous oxygen titration spent 85% of monitored time within the target saturation range, compared with 63% in the usual care group. That's an adjusted absolute improvement of 21 percentage points, with a narrow confidence interval of 18 to 25 percentage points. Clinically, that means patients were maintained within their intended oxygen range for the vast majority of the time, instead of drifting above or below target between routine assessments. The secondary outcomes were equally interesting. Time spent in significant hypoxemia, defined as an SpO2 below 88%, fell from 3.6% with usual care to 2.0% with autonomous titration. Hyperoxemia showed an even larger reduction, decreasing from 29.1% of monitored time to 9.2%. These improvements were consistent across the predefined patient subgroups. One aspect I particularly appreciated is that this trial doesn't portray oxygen therapy as simply turning oxygen up or down. Instead, it treats oxygen as a continuously titrated medication, one that deserves the same precision we expect when adjusting vasopressors, insulin infusions, or ventilator settings. That concept may ultimately prove more important than the technology itself. Of course, several limitations deserve discussion. The study was unblinded, which was unavoidable given the intervention. More importantly, the outcomes were physiological rather than patient-centered. We still don't know whether spending more time in Normoxemia translates into fewer ICU transfers, shorter hospitalizations, or improved survival. The intervention also relied on continuous pulse oximetry and specialized equipment that may not yet be widely available. So, should this change practice? Not by replacing clinicians. Rather, it suggests that continuous automated oxygen adjustment may become a valuable extension of clinical care, particularly in busy hospital wards where frequent manual titration is difficult to sustain. As healthcare increasingly incorporates artificial intelligence, this study offers a practical example of where automation may provide measurable benefit, not by making diagnoses or replacing clinical judgment, but by reliably performing repetitive bedside tasks that humans simply cannot do continuously. In practice, this means we should begin thinking of oxygen therapy as a dynamic treatment that requires ongoing adjustment. Whether autonomous oxygen titration becomes standard practice will depend on future studies demonstrating improvements in patient outcomes, workflow, and cost effectiveness. But this trial provides convincing evidence that maintaining patients within their intended oxygen target is far more achievable when technology helps close the loop. Few areas in pulmonary medicine have evolved as rapidly as the diagnosis of peripheral pulmonary nodules. For years, the decision was relatively straightforward. If obtaining the highest diagnostic yield was the priority, CT-guided transthoracic needle biopsy was often considered the benchmark. Bronchoscopy, on the other hand, offered a safer alternative, but generally came with a trade-off: lower diagnostic performance, especially for smaller peripheral lesions. But is that trade-off still real? That question was addressed in a study published in Chest in August 2026, comparing cone beam CT imaging-guided bronchoscopy with CT-guided transthoracic needle biopsy for diagnosing peripheral pulmonary lesions. This was a single-center, retrospective, comparative cohort study, including 895 patients undergoing biopsy of peripheral pulmonary lesions. The investigators compared two commonly used diagnostic approaches: cone beam CT-guided bronchoscopy, most performed with robotic assistance, and CT-guided transthoracic needle biopsy. Rather than focusing only on the pathology obtained during the procedure, the primary endpoint was diagnostic accuracy confirmed after 24 months of clinical follow-up, providing a more meaningful assessment of whether the initial diagnosis ultimately proved correct. That distinction deserves attention. Immediate diagnostic yield tells us whether tissue was obtained. Diagnostic accuracy tells us whether the procedure led to the correct clinical diagnosis. For patients, the latter is what truly matters. And that's where the results became particularly interesting. Diagnostic accuracy was remarkably similar between the two approaches. Cone beam CT-guided bronchoscopy achieved a 24-month diagnostic accuracy of 90.7%, compared with 92.6% for CT-guided transthoracic needle biopsy, a difference that was not statistically significant. If the study had ended there, the conclusion would have been simple. Both procedures perform similarly. But the safety data tell a much more compelling story. Overall complications occurred in just 4.3% of patients undergoing cone beam CT-guided bronchoscopy, compared with 41.6% after transthoracic needle biopsy. The difference in pneumothorax was even more striking. Only 1.8% of patients undergoing bronchoscopy developed a pneumothorax, compared with 31.4% in the transthoracic biopsy group. Severe bleeding or cardiorespiratory failure was also less frequent with bronchoscopy. For clinicians who routinely perform lung biopsies, these are difficult numbers to ignore. The bronchoscopy approach also offered something that transthoracic biopsy simply cannot: simultaneous mediastinal staging. Among patients who met criteria for invasive nodal staging, 86.5% underwent mediastinal staging during the same procedure when bronchoscopy was used. In contrast, only 14% of patients in the transthoracic biopsy group underwent staging after their biopsy, requiring an additional procedure. Radiation exposure was similar between the two techniques. From a workflow perspective, that has important implications. A single procedure can establish the diagnosis, stage the mediastinum, and potentially shorten the pathway to definitive treatment. Of course, this study should be interpreted in context. It was retrospective and conducted at a single, high-volume academic center with extensive expertise in advanced bronchoscopy. Outcomes achieved in such an environment may not be immediately reproducible in centers without access to cone beam CT technology, robotic platforms, or experienced proceduralists. Patient selection may also have influenced which biopsy technique was chosen. An accompanying editorial highlights another strength of this work. By using 24-month diagnostic accuracy rather than immediate diagnostic yield, the investigators evaluated what ultimately matters to patients: the correctness of the diagnosis over time, not simply whether tissue was obtained during the procedure. So, should this change practice? For centers with the necessary expertise and technology, these findings strengthen the case for cone beam CT-guided bronchoscopy as the preferred initial diagnostic approach for many peripheral pulmonary lesions. Comparable diagnostic accuracy, dramatically fewer complications, and the ability to perform mediastinal staging during the same procedure represent a meaningful combination of advantages. In practice, this means the conversation is shifting from which procedure has the highest yield to which procedure provides the best overall diagnostic strategy for the patient. Increasingly, those are not the same question, and advanced bronchoscopy is making that distinction harder to ignore. When an ARDS patient becomes more hypoxemic, our instinct is almost automatic: increase the PEEP. If the oxygen saturation improves, we often feel reassured that we've made the right decision. But here's the question: what if the lungs look better while the patient is actually receiving less oxygen at the tissue level? That's the central message of an outstanding review published in Intensive Care Medicine in August 2026. Rather than introducing a new therapy, the authors revisit one of the most important and most frequently overlooked concepts in critical care: heart-lung interactions. This is where many clinicians make their first mistake. We often judge the effect of a ventilator change by looking at the oxygen saturation or the arterial oxygen tension. Those numbers are important, but they tell only part of the story. Remember, oxygen delivery depends on two major components: arterial oxygen content and cardiac output. If you improve oxygenation but significantly reduce cardiac output, tissue oxygen delivery may remain unchanged or even decline. Think about that for a moment. The number on the monitor improves. The physiology may not. That's because positive pressure ventilation affects much more than gas exchange. As intrathoracic pressure rises, venous return falls. At the same time, alveolar overdistension can compress pulmonary capillaries, increasing pulmonary vascular resistance and raising right ventricular afterload. Meanwhile, the increase in pleural pressure actually reduces left ventricular afterload, which can benefit patients with left ventricular dysfunction. The overall hemodynamic response depends on the balance between these competing effects. In other words, the right ventricle becomes the integrator of heart-lung interactions. If the right ventricle tolerates the increase in pulmonary vascular resistance, recruitment may improve oxygenation without major hemodynamic consequences. But if right ventricular function is already marginal, the same increase in PEEP can precipitate RV dilation, reduce left ventricular filling, decrease cardiac output, and ultimately compromise systemic oxygen delivery despite a better arterial oxygen saturation. That's why the review argues that PEEP should be viewed not simply as a treatment, but as a physiological test. After increasing PEEP, don't stop at the blood gas. Ask 4 questions. Did oxygenation improve? Did respiratory system compliance improve, suggesting alveolar recruitment? What happened to dead space ventilation? And perhaps most importantly, what happened to cardiac output and right ventricular function? Taken together, those answers tell you whether you've recruited lung or simply over-distended it. The review also reminds us of an important physiological principle that is easy to forget. Pulmonary vascular resistance follows a U-shaped relationship with lung volume. At very low lung volumes, extra-alveolar vessels are compressed. At very high lung volumes, alveolar capillaries are compressed. The lowest pulmonary vascular resistance occurs somewhere in the middle. That means both under-recruitment and over-distension can increase right ventricular afterload. More PEEP is not always better, and less PEEP is not always safer. The review also challenges another common misconception. Many of us use pulse pressure variation or stroke volume variation to assess fluid responsiveness. But in patients with significant right ventricular dysfunction or elevated pulmonary vascular resistance, those dynamic indices may reflect cyclic changes in right ventricular afterload rather than preload responsiveness. Conversely, in patients ventilated with low tidal volumes and poor respiratory compliance, these indices may underestimate true fluid responsiveness. Without understanding the underlying physiology, they can be misleading. So, what should we do differently? The authors advocate for a more integrated bedside assessment. Changes in oxygenation should always be interpreted alongside respiratory mechanics, dead space ventilation, hemodynamics, and, whenever the response is uncertain, bedside echocardiography to evaluate right ventricular function and cardiac output. In selected patients, more advanced hemodynamic monitoring may also be appropriate. This isn't a paper that changes guidelines, it changes perspective. In practice, this means that every adjustment to PEEP should be treated as both a respiratory and a cardiovascular intervention. Improving oxygenation is important, but it isn't the destination. The real goal is improving oxygen delivery to the tissues while avoiding right ventricular injury. Because in ARDS, the ventilator isn't just treating the lungs, it's treating the heart as well. Every week, hundreds of papers are published. Only a handful have the potential to influence how we care for patients. Those are the ones we try to bring to you. Whether the impact is immediate or simply changes the way we think, staying current isn't about reading everything. It's about recognizing the evidence that's worth your attention. I hope this week's discussion helps you do exactly that. If you have a different interpretation of these studies, or if there's new evidence you think deserves a closer look, I'd love to continue the conversation in the comments. Thank you for listening. I'm Dr. Aladdin Sagar, and I'll see you next week for another edition of This Week in Pulmonary and Critical Care Medicine.